Good morning. Good morning, everybody. Thanks to everybody for coming. We have a great presentation today. I'm really excited about it. I'm Ed Hurwitz. I'm the Learning Health System Clinical Champion for Michigan Medicine and one of the leaders of the LHS Collaboratory. We're going to have a great presentation today to find out more about how learning health systems apply out in the real world and some of the things that come up.
Thing to do if it was like
selfishly.
Okay. All right. I needed the help. Okay. All right. Okay. So thanks for joining us. Today's session is being recorded and will be available on Learning Health System YouTube channel. For anyone joining on Zoom, we kindly request that you keep your mics muted. We'll have time for audience Q&A, so please enter your questions in the link for the chat. I'm going to encourage the folks who are on Zoom, when you enter questions into the chat, please try and enter nice, pointed, focused questions that maybe have single points to them. We tend to get these essay questions on Zoom, so try and think about, is this a question that can be answered shortly rather than being a whole essay? So thanks for thinking about that. Okay, if you want to see me credit, here's the activity code. Give everybody a chance to point their phone. So if you need it, all right. And then you see some of the instructions there. And again, this will be online if you need to look back again. All right, so we started with the introductions for Michigan Medicine on the road to becoming a learning health system, viewpoints of 4 trailblazers. So who are our trailblazers? So let me introduce Dr. J.T. Eckner, James Eckner, J.T. Eckner is what we call him. He's Director of Clinical Research at the Michigan Neurosport. Dr. Eckner works with elitist athletes at the University of Michigan and the USA Hockey National Team Development Program. His primary research interest is mild traumatic brain injury in athletes, and his work addresses concussion risk, biomechanics, and assessment. His current research funding includes a K-23 Career Development Award from the National Institutes of Health, as well as research grants from the NCAA, University of Michigan Injury Center, and Foundation for Physical Medicine Rehabilitation. Next, we have Dr. Joyce Lee, the Associate Chief of Medical Information Officer for Pediatric Research. Dr. Lee is a unique triple threat leader, a practicing endocrinologist, a board-certified clinical informaticist, and a health services researcher. Her work falls under the broader framework of LHS, and her current focus is on type 1 diabetes. She's also on the leadership for the Michigan Collaborative for the Type 2 Diabetes and is the Director of Life Course Research Informatics Core and an NIH-funded core of the Michigan Nutrition Obesity Research Center. Then we have Dr. Stephanie Taylor. Dr. Taylor is a professor of internal medicine and chief of the Division of Hospital Medicine at Michigan Medicine. Dr. Taylor is a clinician researcher with deep expertise in hospice, palliative care, and acute care outcomes. Her research focus is on using rigorous methods to develop and test complex health interventions to improve outcomes for hospitalized patients. She leads multiple large projects relating to improving sepsis outcome, identifying primary care practices, enhanced pneumonia recovery trajectories, and other areas of care. Finally, we have Dr. Alexandra Vinson, Assistant Professor of Learning Health Sciences. As a sociologist of medicine, Dr. Vinson explores the human side of the road to LHS, how our profession adapts to change, and how multi-stakeholder engagement drives the system transformation. At Michigan, she co-leads the bipolar disorder learning community and as a multi-stakeholder healthcare improvement collaborative that works to build an LHS to produce improvement in organizational care processes and health outcomes for individuals with a bipolar diagnosis. So I hope you are all suitably impressed with the speakers that we have today, all very accomplished folks. And we will start by having them all come on down. Come on down. Okay, so we've asked everybody to give a like up to a 10-minute presentation about the work that they're doing. So why don't we start with Joyce? Joyce, do you have slides?
I have no slides.
No slides, fine. Okay.
Yeah. All right. So I am a pediatric endocrinologist. I've been here since 2003 and live in the Cheer Center. In terms of, I guess, my journey, so started out as health services research. I've always been a practicing clinical endocrinologist, and then KR, and then felt like I needed to do something that was a little bit more real world. We were doing a lot of secondary analyses related to obesity and diabetes in the pediatric population, but I think, the electronic health records and methods of continuous and quality improvement really came about. So in 2018, became an Epic Physician Builder, really pivoted towards informatics as a core focus, and then did some training in advanced methods and quality improvement. So kind of caught up with Alexandra through Cincinnati a little bit. So currently, in terms of sort of areas of focus, what I have done is definitely had an informatics bent to what I do, and it really is embodied in the leadership positions that I have right now. So I lead informatics and clinical innovation for the Caswell Diabetes Institute. So I have a team that works with us to deliver electronic health record data. We have a repository. We do a lot of consultation to help individuals understand how to measure things that are already being done in the system that they didn't know could be measured and perhaps are not in traditional data models like RDW, because these are more operational workflows. We help them understand what tools they need to ask for to integrate measurement and or process or outcomes into the EHR so that they can measure continuously whether processes are being improved and or whether outcomes are being delivered. And then we've also done sort of like different kind of help them develop different tools. So for example, Dina Grausta is a researcher who does a lot with nutrition interventions and keto. So helped her develop a care companion intervention that essentially is a care plan that can be delivered as a digital tool within the portal. It's basically built inside Epic with some questionnaires, some links to educational videos, some tasks. It can be sort of, patients can be assigned, and then it can deliver modules at a particular time frame and cadence. So she's unrolled that, and it has reached, I think, at least like 800 to 900 patients in the health system. And the idea is it's going to continue to grow over time, but trying to think about how do we leverage the one tool that governs our lives as clinicians and helps us really move towards utilizing that to achieve some of the goals that we want to achieve. So I've done some sort of smaller projects in pediatric diabetes. We definitely assist others with quality improvement activities. Like we're doing some work in childhood obesity right now. We have done some work with diabetes distress screening on the adult side. So we try and support any researcher, any learning health system folks who are really interested in doing things inside the health system around metabolism and obesity and diabetes. So the only other thing I guess two things. So we had the support from Caswell. It's ongoing. Two, we've gotten some independent funding to support some of our work, some of the improvement work. And then we did start out as the Childhood Obesity Research Corps, and now our Life Course Obesity Research Corps as part of MNORC, which is an obesity center. So we're pretty much the only clinical group inside that set of cores. And the way we actually shopped or sold the grant was that we really wanted researchers to do real world activities. So everything is about real world data and implementation, and how do we help researchers leverage what's inside. So that has been sort of an opportunity for us to bring in sort of NH funding into the work that we do. And then I just want to make one comment. So I am an ambulatory leader now. I'm one of the new clinical domain oversight officers. So I have in my portfolio adult medical specialties, pediatric medical specialties, and psychiatry. And in ambulatory, we're all about volumes, access, right? So I do see a huge opportunity to sort of link some of this. I've been working with primary care. I've been working with adult endo and peds endo. Now I actually work with them operationally. So then the question becomes, how do we synergize and think more integratively about how to sort of stop the siloization of opportunity at Michigan Medicine and try and bring it together. So those are just some of my thoughts. Thanks.
Great. JT Eckner.
Guess I'm next. Hi, JT Eckner. Sorry, my picture's a little dated, as was my bio, but that's okay because I'm going to talk about our concussion LHS journey. And I would say our journey probably starts when I looked like that, actually. So I feel like actually our LHS journey has almost a prequel to it. So I would say the prequel to our journey is that within our concussion group, Neurosport in particular, this is probably like back in the early 2010s era, we realized we had a lot of fellowships, fellows who were doing research projects as fellows, and they were running into the same problems with their EMR-based research projects that everybody else runs into. Information that we thought would be there wasn't there. Information we thought would be clear was ambiguous. And so before we even knew that a learning health system was a thing, within our group, we were talking about trying to standardize the way we all documented our clinical encounters. At that time, I was actually still like calling up the dictation service and like, this is James Eckner, 14900, blah, 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 and doing a, completely unstructured note. Some of my colleagues were using one template, other colleagues were using other templates. So our first full challenge was just deciding like, how are we going to agree on how to all document our clinical encounters together? And as we were doing that, we decided that we liked the note writer template format in MyChart. It's nice in that you can click a bunch of buttons while you're talking to the patient, generates a note for you. I'll talk about some of the challenges with it in a minute though. And we decided on our journey, let's start with the physical exam. We thought that should be low-hanging fruit that we could agree upon and do fairly easily as a starting point. So while we were working on that, Ed was my chair at the time, and he invited Chuck Freeman to come to our department and talk about learning health systems. And I was like engaged. I don't know if I'd realized how engaged I was, but I was like, wow, this is great. There's like this whole practice to data and data to knowledge and knowledge to practice. That makes so much sense. And I was like, this is amazing, A. I was like, B, we should totally do this. And I think actually we've kind of started to do this. And C, like, let's go. So I went and talked to my team and we were like, yeah, this sounds like a great opportunity. This sounds like the future of medicine, really. So we were very excited at this time. And we started trying to pursue, how do we actually build a formal learning health system? And I think one of the things that we heard loud and clear at that time is there's no one way to build a learning health system. Every LHS is going to be a little bit different, which if you're a glass half full kind of person is like, wow, there's all these like exciting opportunities and different options. But for us, I don't want to be a downer, but it was a little bit of a glass half empty that kind of translated to like, you kind of have to figure this out on your own. And so it's very much felt like a process where we're kind of like building the plane as we're flying it. I've used that analogy many times. Sometimes the plane crashes a little bit, but we get it back up again. 2 steps forward, 1 step backward kind of thing. So I think Chuck came and talked to our department around 2015. So this is literally like an 11-year journey that I'm talking about here. And so one of the things that we did initially that we hadn't already thought about was building a learning community. It's like an important part of a learning health system. And I would say we had already done a pretty good job of like combining all of the clinicians, like, the physicians from PM&R and neurology and athletic medicine. We had like our PTs, we had our neuropsychologists, we had our social workers. So I think we did a good job of getting clinicians on board even before we knew a learning health system was a thing. But we didn't really engage patients in it. We didn't really engage administrators in it. So we did make some efforts to engage patients and administrators and get feedback from them. And with the feedback, we essentially developed a list of a lot of questions that we thought we could address with our concussion learning health system. And I won't go through like all of them, but I would say the pie in the sky question to me anyway was like, can we develop like personalized like risk stratification algorithms for recovery? Like in concussion, we're getting asked all the time, like, how long is it going to take till I feel better? And in the athlete clinic, like, hey, I'm signed up for this like camp in 2 months and the deposit's due next Monday. Should I put the deposit down? And so, we give like general answers and we use our clinical gestalt to try to individualize as much as we can. But like, I think like, how cool would it be if we were like in cardiology where we can say like, based on your risk factors, your, median recovery time is expected to be whatever, right? So that's like our pie in the sky goal, but lots of additional questions like in between. So we kind of started on this journey. So in terms of the learning community and the questions, we did a good job, I think, initially. We got a pat on the back for like combining a learning community off the bat, but I wouldn't say we do a great job of like maintaining the full learning community over the whole decade since that started. The clinicians are still pretty active and engaged, but we haven't had ongoing engagement from patients and other stakeholders. So that's probably one that we could have done better in retrospect. In terms of like our efforts, they've really focused largely on the P to D arm of the cycle. And I think of the P to D arm of the cycle kind of in 2 parts. To me, there's like the front end part where it's like you're the clinician, you're sitting in front of a computer talking to a patient, you're putting information into MyChart. And then I think of the back end part, which is where like we have a data analyst or somebody else who's able to go and pull that information back out of MyChart. And really, like, that's where our time has gone. It's been like a decade, but that's where our time has gone. That's where our roadblocks have been hit. IT, tech support, it's just been like the biggest challenge for us. On the front end, I think our choice of using NoteWriter was a challenge. I've got additional insight into my chart building that I didn't have when we started this. And NoteWriter templates are actually really complicated to build. And we're not, we're like neurologists and PM&R doctors dealing with concussion. Like, we don't just want to like high level information. We're like looking for detailed information. So we asked, I bet if you asked our builder who was working with us, we probably set the record for like the most complicated build she's ever been asked with a NoteWriter template. So I think that was maybe not ideal. I think we also like tried to take on the world all at once. It wasn't like we had one focused question with a couple of data elements that we wanted to try to answer. We had like a million questions with like very big picture goals. So we tried to do like the entire note. And yes, we did roll it out in phases. I mentioned like physical exam first, but it really took a long time to get this whole NoteWriter template set up. We did eventually get to the point where we had, I wouldn't say perfect, but we had a NoteWriter template and we rolled it out, and I was using it in the PM&R concussion clinic. The other neurosport physicians were all using it in the neurosport clinic. Our colleagues in athletic medicine started using it in like the sports medicine clinic. And I'll come back to our template. On the back end, like getting data out of the EMR, there's more than one way to do that. And, a decade ago, we talked to different groups, and different groups could help us with that. And there were pros and cons, and some had costs, and some had to be, updated as the template got updated. Ultimately, at that time, we had a data analyst in the PM&R department, so we decided to use our departmental data analyst. And it was her first time working with NoteWriter templates, which are not only hard to build, they're also harder to pull data out of. And so, it took a while. There was a learning curve to it. We did eventually get to the point where our data analyst was extracting massive amounts of data from what we had at the time as far as structured notes. We call it our historical concussion LHS data set, historical, because it's not really like a living, growing, functioning LHS where we continue to enter into it and pull out of it. The extracts were done like right before COVID, so that was a little while ago. And during COVID, we actually had team members who had less clinical activity going on who were able to dig in and data clean and add to what was in there. So we do have a historical LHS data set, but we don't have like an ongoing rolling data set. So really, that's kind of a summary of our P to D. I'll be quicker with the D to K and the K to P. As far as D to K, we have used, some or all of that data set. We've published 7 papers, which I think is pretty good. So like we get kudos for that. And if I want to spin the positives, that's definitely one of the things we highlight is all of the papers that we published. In terms of the K to P, I would say nothing in a structured, formal way. We don't have that algorithm working behind the scenes that's giving me like stratification and median recovery estimates and things like that. We're far from that still. But we are certainly like using our clinical gestalt and applying the information that we've gained in an informal way with our patients. So I'd say that's a summary of our different arms of the cycle. I would say the next phase of our journey is within the past couple of years, we finally got this template up and rolling. We were really ready to start focusing our attention on that back end, like getting the data out more regularly. And then go figure, this whole like DAX Copilot, AI generated notes things came on the scene. And so we just got this damn thing going, and half of the providers are now starting to use AI to generate their notes. So in some way, I think we've done kind of a different learning health cycle. We're back to the point where everybody is generating notes in a different way. Some of us are using templates, some of us are using AI. A lot of the information is going in an unstructured way. And so that's like a new challenge. And so the exciting future end to this thing before I hand off the microscope. I recently reached out to Ed and said, Ed, what are we going to do about this? We can't be the only people with this problem. And, in his knowledgeable and fatherly way, he said, no, you're not the only people that have this problem, and we're not really sure what to do about it. So he introduced me to Vinod, and we have a SIF application currently under review to develop what we're calling an AI-powered learning health system. So I guess talk about the future. I guess I don't know exactly how we're going to get there, but we're developing a roadmap of how we're going to get there. And hopefully with the expertise from Department of Learning Health Sciences and our clinical background, and the fact that we now have a wealth of notes that were generated with a template and a wealth of notes that were generated with AI, hopefully we'll be able to get to the point where there's kind of a data in, data out. We don't have to think about it. It's happening in the background. And then we can focus on that, D to K and K to P arm of the cycle. So that's been our journey. And I will pass it off.
Okay, Stephanie Taylor.
hard to follow up on that. I'm Stephanie Taylor. I have been here for about 3 years. I was at Wake Forest for about a decade before that, and I was recruited there specifically to build a learning health system around sepsis at Wake Forest. So if you don't know what sepsis is, if you're not clinical, it's a life-threatening response to infection, very high mortality, very common. If you don't know someone with sepsis, you probably will. So a big opportunity to improve outcomes and a major focus of health systems, both because it's a high cost, high mortality, and there are some, policies around reimbursement and public reporting for sepsis outcomes. So health systems really care about this. So when I got here, I tried to bring a lot of what I had built at Wake Forest here to build a sepsis learning health system, or really we call it the acute care embedded research. So it's sepsis is kind of the central part, but other things that have to do with inpatient conditions. Trevor and Sashita are part of my team, if you know them, helping do the great work that we do. The beauty of my current position, I'm the chief of hospital medicine, is that I sort of get all of the pieces of the learning health cycle kind of directly. So I take care of patients clinically. So I see things that happen. I see things that they need. I can engage with patients easily for their needs. I am an operational leader, so I'm making decisions about what types of interventions to support, to give resources to. And then I'm accountable for all of those things as well. And my research also, focuses on this area too. So what we did, we first kind of built out a data set. So we have members on our team that helped us take EHR data and build a kind of deep, granular, feature-rich data set of sepsis patients so that we could learn from that. And then from there, we listened to our patients, we listened to health administrators about what interventions they were planning, what problems they wanted to solve. And depending on what stage they were on the cycle, we either designed interventions to solve problems, or we built trials to comparatively test different interventions or interventions versus usual care. And then we also focused on implementation science. In sepsis, there are some evidence-based interventions that are not, there's not a wide uptake for. So implementation science is a really big deal. And there's also a lot of unknown in terms of treatment. So a lot of our work is designing interventions and testing new things to see what will work. The other thing that's interesting in sepsis is historically we focused on inpatient treatment and outcomes, but what we've learned from patients over the last decade is that there are persistent long-term effects and bad outcomes that last a year, 2 years, even longer after hospitalization. And so a new part of our research has been understanding how to support patients for full recovery, not this kind of easy to measure inpatient mortality outcome, but what are these more tricky to measure, but really important to patient outcomes in terms of long-term recovery. So we've been working on building interventions to improve that, as well as good ways to test the effect of that interventions in terms of outcomes. You talked about challenges and successes. Challenges are similar. IT support has been, there's just not enough IT support. That's one. One of the main challenges in doing this type of work is the pace. So as scientists, our pace tends to be a little bit slow. We want to make sure the trial is designed as rigorously as possible and the power is as optimized as possible. But the administrators want to know, do I do this or not? And I want to know it tomorrow. And so there's a little bit of kind of mediation that goes on. And again, it's kind of cool to sit on both sides of that. So I can see both sides. But we design as rigorous a trial as possible, as rigorous a research evaluation as possible, making sure that whatever information we present to people, we believe in, it's credible, but we try to do it as fast as possible. And there's some new techniques and methodologic advances that help us to do that, that we've been able to do that with. Our team's been really successful in getting federal funding. I was just talking to Amy about implementation science having a moment, which we're taking advantage of. So this work has probably resulted in 5 or 6 R01s. It's been the basis for 3 career development awards. We've had tons of publications and things like that. So one of the things we really emphasize is the academic part of the work, making sure that we're helping directly local outcomes, but also creating generalizable knowledge that helps, this condition across all populations. So I'll stop there.
Okay, Alexandra Vincent. Alexandra will.
Thank you. I brought a couple slides and I'm going to create some transition time for our colleagues to grab a seat.
Alexandra, just say next slide when you need that, okay?
Oh, wow. This is really cool. Okay, so I'm Alexandra Vincent. I'm faculty in the Department of Learning Health Sciences, and I'm here to talk about the bipolar disorder learning community. This is an initiative of the Proctor program, Proctor Bipolar Research Program in the Department of Psychiatry. And I've been collaborating with this group as part of a departmental initiative for the past 4.5 years or so. And I'm really excited that my co-lead in this work, Claudia Diaz-Bird, program manager in the Proctor program, is with us today. So I will be talking about a lot of things that she and I have developed together over the past several years. As you can see, our tagline here is that we are powered by researchers, clinicians, family members, and lived experience experts. So we started not so much as an outcome-driven learning health system, but as a learning community. And we are now in the process of evolving into a learning health system. Next slide, please. And this one is animated, so for even more fun. Okay, great. So as I was mentioning, we bring together not only researchers, clinicians, people with lived experience, and family members, but recently we've also been integrating a lot of trainees into our work, including some of our Hill students. Next slide, please. Thank you. And so the shared goal of our work is really enhancing well-being. One of the things that makes bipolar disorder like other chronic conditions is that people living with the diagnosis tend to provide a lot of their own care and self-management, seeing their doctors periodically when they need to. And so there's a lot that we can learn from thinking about other chronic conditions and the approaches to them, but it also produces some interesting challenges for our group. So unlike some other conditions, there's not a one-shot easy outcome or obvious indicator for how well someone's doing when they're living with bipolar disorder. There are lots of different patient-reported outcomes measures that we can look at. There are lots of different metrics, but it's not always easy to find the one that everyone can agree is the most important one. And of course, when you build a learning community and you bring in and really robustly integrate and take seriously the priorities of patients and family members, this also moves us away from some of the typical clinical indicators of health. And so one of the interesting things about our group is that we have had to think really hard about how we're going to organize what we do, especially because, like other chronic conditions, the things that are most important to people living with bipolar disorder are things that span the clinic and the rest of life. And the clinic can be, in the hospital, can be a quite small portion of life, especially for people who are living with long periods of wellness and stability. Next slide, please. So this is a brief timeline for our group. We went through a planning phase in 2021 and early 2022 before we officially launched in August of 2022. We went through a really important phase of relationship building, defining our shared work, and actually building our relationships by working together on projects that were more of a healthcare improvement or community-facing project. The first thing we did together was develop a resource list and build a website to put it on, since there wasn't a strong web presence for the bipolar specialty clinic. We also worked on building our cultural infrastructure. So this went beyond our relationships to actually include how we wanted to work together, what values we wanted to bring from the broader Proctor program and add to that really would characterize our work and provide us guidelines for how we would relate to each other and how people's input would be integrated, et cetera. And now I would say that we're firmly into the action phase. Over the last 3.5 years since we started, we have worked in response to primarily lived experience priorities and learned things from our partners like it's really a bummer to fill out a lot of forms every time you go to the doctor, especially when a lot of those forms emphasize all of the deficits that someone might have in terms of their functioning or all of the high symptom burden that they might have. Of course, it's good to know those things so that they can be addressed in the clinical setting. But for ongoing assessment and tracking of well-being, we actually ended up developing a novel individually tailored and strengths-based measure of well-being, which we validated in our research cohort and are now working on further validation and development for. We spent also a long time thinking about, well, if there's a lot of things about living with bipolar disorder that happen outside of the clinic, how can we provide kind of extra clinical support for that? So we began visioning and developing a peer support program specifically tailored for people living with bipolar disorder that would be entirely peer-led by other people with bipolar disorder. And over the last year, we have been piloting that in 2 separate 6-session rounds with trained facilitators who are members of our group and a suite of accessible clinical support as needed. And in about 2 weeks, we'll complete our pilot. We'll learn from our data, and then we will hopefully be able to have a robust discussion about what we should do next. More broadly, we're working on capacity building. Could you go back for 1 second, Ed? We're working on capacity building for research and clinical integration, which is really the future direction of the Practor program, to be able to take what we learn from all of the research that's done in the Practor program and use it to directly inform clinical care, and then to be able to have clinical care feedback into our research priorities as well. So Ed's showing, this is what I'm calling the strategic pyramid. So at the very top of the pyramid, our starting places are why. These are the values that I mentioned that we organize our work around. On the next row, we have the what. So these are the big strategic priorities that we have: enhancing well-being, improving the patient and family experience, and co-producing innovations in research and clinical care. And there's lots of little, if you can advance the slide, there's lots of little activities that we do and sort of tactics that we use to meet this mission, some of which I've mentioned are the well-being measure, our patient and family resource list, our peer support program, our educational one-pagers, and some of the future-looking initiatives that we have around understanding patient journeys, improving accessibility, et cetera. And I think I have one more slide. Just want to show this without, it's animated. But you all will know this. This is a tornado diagram. And if you can click through, you'll just see how we map our different initiatives on here. And that'll be my final slide. Thank you.
Great. Thank you so much. So much to talk about. There's questions online. I'm sure there'll be questions in the audience. But I want to start with this. The last slide we just showed, it was the classic picture with the, at the bottom is the infrastructure. People, technology, processes, and policy. If you were to think about the journey of Michigan medicine toward a learning health system, and I'm sure many people have heard that there's the learning health system has been written broadly into the strategic plan by our new dean, and we're having a summit in the fall to talk about how we move Michigan medicine forward. If you think about the infrastructure, what should we emphasize? What should Michigan medicine emphasize in that infrastructure model to move the efforts of your learning health system activities forward, and maybe just in general? So let me open that up to everybody to think about and see what you have to say.
We actually have a lot of capacity. We have a lot of analytic capacity in this system, but I would say we're very splintered and we're very matrixed. And I think part of that comes out of people wanting more. So then every department hires their own analyst, right? Which serves a need, but also indicates that we need a little bit more of a strategic vision on how to improve on data governance and make sure that we're not reworking and redoing work all the time for the same variables. I guess the other thing that I would just comment on, and part of my frustration with data came out of the fact that, one, it wasn't being measured. Like, we didn't measure distress. We didn't measure self-management. We didn't measure the thing, do you use a CGM? Like, we didn't measure the things that actually mattered for outcomes. So part of that was rejiggering the EHR to actually capture those things in an effective way in a reliable way by the workforce so that it's continually measured over time. Two, it's how do you get that out of the EHR and how do you make elements that are structured and clean and understood by many different parties, right? And yeah, smart links aren't, or yeah, like note writer, that's not the way I would have done it, but I had the benefit of going a little bit, yeah, right? Like, and so I think there's that piece, but I think one of the things that we're still grappling with, and I think I'm doing a lot of this work actually for the Department of Pediatrics and also for ambulatory, we need data for humans. Right? I mean, I think we get a lot of data. There's a lot of spreadsheeting. There's a lot of information, right? But the extent to which it's actually unified, integrated, and allows me as a clinical leader or as an administrative leader to actually make the right decision at the right time with very little work, that is the piece that I think we have the biggest opportunity for. So I guess what I would say is I translate data to humans. So that would be sort of my thought about where we have opportunity. That interface is hard. I do Epic. I know Clarity. I work with excellent analysts, but I know, and I build dashboards, right? But that's because I can actually dialogue with myself and I can forego 20 emails, 5 meetings, and 3 months of time by doing that. So we need more of that inner layer. And I'm not saying it always has to come from a clinician leader, but there's got to be a better way to do it.
I'm impressed you can do that with that few meetings and emails, Joyce. JT.
I would just agree. Like, to me, I think the IT infrastructure would be like more accessible and clearer IT infrastructure. Like, yeah, it would have been great to know 15 years ago that NoteWriter is not the most easy system to work with, right? That would have been really helpful information back then. I mean, around COVID, I actually like took the builder classes, and I don't have a coding background. And like, yeah, if I had like all week, I could do this stuff. It took me forever. It really wasn't practical. So that was a little bit more time wasted in terms of like getting the builder credentials. Like, we did have a great builder, but yeah, it was like, I mean, literally, like you'd talk to the builder like once a month, every couple of months, and every time it was just another back and forth and a back and forth. And it, weeks became months, became years before this thing finally like got to the point that it was usable. So I think like in my analogy, we were building the plane as we were flying it. Like, it'd be great if Michigan Medicine had a plane or a couple different planes that we could hop onto and just fly wherever we need to, rather than building them ourselves. So like, hey, you want to build an LHS? Talk to this person, read this booklet. Here's how you do it. This is one option. This is another option. If you're going to do this option, these are people to talk to. You do that option, talk to these people, rather than like, I don't know, let's Google University of Michigan, data services. Okay. I mean, it was really like, yeah, that's my thought.
I think this is part of infrastructure. I don't know if this is what you were meaning, but in our work, sort of the culture of the clinicians or the clinical teams is an important area that I think needs a little bit of transformation in the. Obviously, there's autonomy as a practicing clinician, but this openness to generating evidence and acting on that evidence in areas where there's equipoise has been challenging in coming over here. In our pragmatic trial work, we will randomize people to do one thing or another where there's complete equipoise, obviously, or we would be doing the trial. But we'll have clinicians that just say, no, I'm not doing that because I think A is better. And we're like, well, there's no evidence that A is better. And they're like, well, I'm doing it because I think A is better. And they're unwilling to sort of participate in these knowledge generation characteristics. And I think that's going to be something you have to overcome as a culture. Places like Vanderbilt and NYU and other places have made that happen relatively quickly. But I think there has to be a critical mass of people doing that type of work to get everyone on board with understanding why that's so important. And on the flip side, we'll get messages from the quality team that we're rolling out this initiative. And I'm like, well, does it work? And they're like, yeah, we think it works. And I'm like, well, how do you know? Let's find out. Does it work? And like, everybody gets it because we think it's going to work. And so let's test it and find out. And they're like, no, because that wouldn't be fair. We want everyone to get it because we think it works. So I think there is some culture transformation.
That's great. I just passed Alexandra. Before we do that, I just want to say that one of the main things that we faced at PM&R was, you're adding to my work. I don't know what you're talking about. I don't know what these 3 letters mean, but you're adding to my work, right? You're trying to add to my work. Forget it. That was a big barrier.
Yeah, I agree that there could be like ways that we develop common ways of talking about data together that really transcend expertise about data. So for example, I don't have as much experience with working with healthcare data. I can't code. I'm a sociologist. But what I can talk about and what I can bring to this is the idea of social review of data. So dashboards are incredibly helpful for certain positions, particularly in an operational setting. But I think I haven't seen a lot of examples of frontline clinicians using dashboards. There's a lot of preference for something that would be integrated into a platform that they're already going to use. And lots of talks about extra clicks. But one of the things that we can do is actually enhance kind of IT and data capacity across the entire spectrum from research to clinical care by convening people, preparing data in advance, and setting the stage for some of these conversations about what should we do next that are actually the organizational and mechanistic basis for learning, so that we also demystify and make learning happen together in public in a way that is not left to the individual. And hopefully that would create more of a situation where people are seeing the changing tide around using evidence to inform practice and to create also a culture of accountability for acting in line with agreed upon plans or agreed upon improvement ideas in the clinical setting.
It's great. More comments on this?
No, I was just going to add something that I've been talking about a lot. I don't know what the right answer is, but obviously making data easier to get is really important, but it can also be dangerous if everyone has access to dashboards and graphs and lines, and people start making clinical decisions based on a small blip that's, within the margin of error if you knew how to analyze that data. So while making data more accessible, I think, is important, I have seen it go wrong when it's not paired with either access to people who know how to make decisions out of that data or skill building. Yeah.
I think we can answer that, Stephanie. We have to make good data available. I've dealt with a situation where we got some bad data. We thought we had a problem. We started to put a mechanism in place to solve it, and then they came back and said, "Oh, no problem. Sorry, we messed it up."
Yeah.
Let me take a question from online, from Greg Merritt. Why do you think it's so challenging to include patients and those that love and care for them to be involved in learning communities? What are some innovative ideas? And I think even more interesting to talk about incentive alignments to improve this. Open up to anybody.
I have the mic in front of me, so I guess I'll start. It wasn't necessarily challenging for us to engage the patients, but again, we didn't do a great job of maintaining them in our learning community. I think for our injury, for most patients, it's a temporary injury. They're not concussed forever. And so I think that's, in our particular world, maybe part of the challenge compared to somebody with a more chronic condition where they may be more engaged like over the long term. I guess that's my insight. Of some of you guys that maybe have more success maintaining engagement with patients might have additional thoughts.
Yeah, we haven't had a ton of trouble engaging patients either. In sepsis, it's usually a life-altering event, so people are usually pretty engaged, and family members are usually pretty engaged. There are challenges with keeping them involved in the research process. There's their time. I think the person asked the question was talking about incentives. So some of the funders like PCORI allow you and want you to pay patients for their participation, which is very appropriate. But outside of that, there's not always a way for us to give the patients financial incentive, which we should be doing because they're spending their time helping us. And sometimes there's a skill, is skill the right word? If we're engaged in a deep discussion about the hierarchical correlation structure of our stepped wedge randomized controlled trial, patients are like, "Oh, I didn't really want to hear about that." But making sure that you're asking the right questions and you can schedule your meetings in a way that allows the patient voice to be heard in areas that it needs to be heard, but doesn't weigh them down with extra time. I don't know if you have other thoughts on that.
So in the bipolar disorder learning community, of course, we have an integrated group that has steady membership of patients and family members. And many of the those partners who collaborate with us have been collaborating with us for several years now. We do provide an honorarium for their participation. As you mentioned, it can be really difficult to find a way to get funds to patients, especially outside of something like a PCORI grant. In order to resolve this, of course, we benefited from some philanthropic support that provided us unrestricted funds that could be designated for that purpose. It obviously wasn't as simple as that, leading us to develop a new contracting process. If anyone is interested in using the contracting process, it was subsequently approved by OGC and is a procurement template that can be used to support honorarium payments for other learning community settings. It's really worth it. We haven't found massive challenges in recruiting patients and family members to partner with us. And I think the longevity of their engagement is an indicator of a pretty good experience overall. We've also made changes to both implement capacity building opportunities, especially when it comes to research familiarity. We work very hard to prepare data so that it's interpretable, and we allocate the amount of time needed to go over that data to make sure that people understand. There can be a lot of talking about the same thing a few different times in a few different ways that supports people participating, but our expectations around engagement and partnership in our learning community are at a quite high level. We look for people who are interested in engaging at the levels of collaboration and shared leadership, and we don't function or we don't integrate patients and family members in an exclusively advisory capacity. So it's really important to build in the time for capacity building, especially because we want our initiatives to be driven by the priorities of lived experience. But this means that we need to keep people engaged in actually doing these initiatives over time so that it isn't, oh, I have a really good idea about something that would help me and people like me. Can you do it? It's, can we do it together? And when we build this base over the course of years, and we have a very long-term vision for what we can do, the projects that we have been able to accomplish have gotten more and more complex over time.
In terms of innovative solutions, the Sepsis Alliance, which is a foundation of sepsis patients and advocates, recently started an initiative called Patient Advocate Academy. And so they train a group of patients in kind of basic research methods and how to be a stakeholder engagement and things like that. And the patients have loved it. And those patients come out like engaged and excited to participate in research and feel like they're empowered to be a part of the team. So I would love to see other organizations or health systems or some organization support patient academies to be able to learn a little bit more about how to participate in research.
So I echo all of those comments, and I would love to hear your hack about OGC and what that is, because we've definitely run into like whatever the max is for the health system per year per patient. I just want to make one more comment. I think some of the hesitation, we've done engagement of a variety of different sort of local and or national projects, but I will say that sometimes when you bring really amazing patients in particular, for example, type 1 diabetes, like they know way more about the disease than we do. Like they drive it. They've done all sorts of really innovative collaborative things right in the community to which we're like trying to catch up. I think there's always this sense of like, you have so many great ideas and then I can't implement most of them. I think there's like a sense of disappointment because of the structures that we have, the unions that we have, the regulations that we have, where they're really great ideas, but like hitting them by getting them so involved. So I just wanted to articulate that sort of side of the coin.
It's a really interesting puzzle. One of the things, the way that we, and I'll just say we and claim it in the Department of Learning Health Sciences, the type of learning health system, one of the types that we want to support is this highly collaborative, participative learning health system. And if you haven't seen it, Chuck Friedman and Sarah Green have this amazing paper out recently that's a typology of learning health systems. And these highly participatory learning health systems, one of their goals is organizational culture change and organizational change over time, which means that if we are building learning health systems, and if we are saying these learning health systems should have a robust learning community that integrates patients and family members at different, specified engagement activities and ways to engage, that it comes along with it this idea that we should be promoting a willingness, like a kind of political will, as well as a hope for the future and willingness to work for it, that some of these structures should be able to be changed to facilitate a broader embrace of patient priorities, innovative ideas, new ways of doing things broadly. And that really is the transformative call of the learning health system. And so I do think that if we begin putting our shoulder behind this as a health system, or even as a collaboratory, as a smaller subset of the health system, we've got to have that type of vision and that type of hope.
Let me ask if there's a question from the audience. Yes, Dan.
Thinking back over the years, I remember a time when the biggest problem was the fire hose of the search coming on how practice should change. And going back to my career, all through the 80s, 90s, developing the guidelines. Then in 1990, structure consolidating healthcare, national oversight, changed infrastructure. That has been changing more rapidly. Starting around 2005, 2010, the whole data side started changing. I could argue at this point that the infrastructure for healthcare and infrastructure for healthcare data are now even more of a fire hose of change than the actual clinical change. When we talk about the healthcare system supporting these subsystems working on particular areas, that fundamental bottom on that tornado diagram, it shows a static and there's no motion in it. I suspect that there's a bit of a blind spot with your theory. If I wish I knew data then, data now, but we have data now that go into indigenous data processing. Do you have any thoughts as you reflect on here? That's a long preamble. Do you have any thoughts as you reflect on change in those three areas, the content of care, the infrastructure for delivering it, and the data to understand what's happening? Where do you think the healthcare system could help move the learning forward, realizing all of these variables that work there?
Yeah, I just want to, for the people online, just quickly say that you're wondering about changes in certain areas, the infrastructure of data, the
whole data system, structure of care delivery,
the infrastructure of care delivery,
you have to input,
and the implementation of new medical knowledge into the system. What has changed to see? What changes have we seen in that?
So I just want to comment on the data piece, not on the entire piece. I think because of how things are changing and because of where we are with our knowledge and understanding of how to use data, meaning data literacy, I think that's a huge opportunity because it's actually not about what you know, and it's actually not about truth. It's about how do you have the method to understand what truth is in every new reality that gets generated every month, every year, every 5 years, every 10 years, right? So one of the things that I did like a year and a half ago as part of a leadership course that I did for Drexel, right, is I convened a group of data stewards, right? And it was individuals who don't have technical expertise. They don't know MyChart well. They don't know anything about the Clarity data model, and they're not necessarily analysts per se, right? But they might be clinicians, they might be improvers, they might be researchers, right? And it's this question of how well you train people to interrogate the data, to make sense of it, and to believe it or to not believe it. So it's sort of like anytime anyone gives you anything, whether it's a summarized dashboard, whether it's a regression model, whether it's a AI generated new data source that comes out of magic, and reflects truth. Like if we don't interrogate it and we don't train people how to interrogate it, like we are all going to be lost and we are going to do dangerous things for our patients if we don't do that, right? So to me, it's about the meta level of training people to be critics, but like to not take things blindly, right? I will say that in ambulatory, we do a lot of vibe, right? We like, hey, let me open the chart in my chart. Let me see, I'm going to make a decision on this. But like we all need to be better about using data as our daily habit and then being very critical of it at certain instances. And of course, you need the persistence of it. Like it can't be there and then be gone. Because if it's not there, we all go blind. And then we start out where we started in the first place. So.
Guess I'll go next. I don't know if I have a direct answer to your question, but I guess just a couple thoughts. I don't have the longitudinal perspective on the health system that you alluded to, but I would say at least in my day, like I do remember going from paper charts to electronic medical record, and that was a huge shift. And pros and cons, right? I mean, the electronic medical record facilitates learning health sciences. Like it's going to be really hard to do that with paper charts. But at the same time, it kind of becomes like a cart before the horse. Like how much time do clinicians spend like documenting versus actually like listening and making recommendations? And then, I mean, another part of it, and this isn't directly your question, but another part I do worry a bit about is like the amount of incorrect information in the chart. Like, I don't know what the percent is, but like a large percentage of medicines on medicine lists are just not right. Like I took that medicine 8 years ago and it's still on my chart. It was like a prednisone burst and taper. It shouldn't be on there anymore, Yeah. So I do think there's also not only danger in not knowing how to interpret the information, but like not knowing how to filter, is this even like right? So I guess those are a couple of thoughts, in terms of the longitudinal nature. It also has, I think, implications like outside of learning health sciences, just for like medical education. I mean, I think like back in my day, I would like make my problem list and kind of organize it. And now like you can just copy and paste and, note load, and it looks like an extensive amount of medical decision making that might not be any medical decision making. And so I think for our trainees, that's also got implications in terms of like their learning process and their thinking through, patient care.
Yeah, I'll just say I think that everything you said is the foundation for why infrastructure for rapid pragmatic trials is so important, because we need to be able to have a system in place to quickly address some of the questions that come up, the fire that you have to find a problem for immediately as new technologies come on board, whether or not they're worth investing in or not. So there's questions we have to answer quickly. Old technology old clinical care delivery models might be out of date quickly, and we need something. And so this model of it takes 5 or 6 years to run a trial to find the answer, and by that time, no one's doing that practice anymore, or that data is old. It is not going to really suit the times. And so I think a system-wide infrastructure to be able to do that fast and nimbly is really important.
I'm going to go in a little bit of a different direction and try to address your $1 million question by saying what kind of science we would need in order to answer your question. So I think that there are lots of different, when you think about taking a health system and transforming it into a learning health system, it's a tremendous organizational change management challenge. And so this means that there has to be tailored science of leadership for learning health systems. We may not be able to take another leadership approach out of the box and expect for it to help us with a large organizational transition like this. We also need a science of grassroots action. One of the interesting things about learning health systems is that they both have to have a grassroots energy to promote acceptability and to help figure out what the direction for change could be, or a fruitful direction for change. And it has to meet somewhere in the middle with this top-down organizational change management and leadership strategy. We also need a science of infrastructure, because we're constantly trying to make something visible and make it better, something that is by definition supposed to fade into the background or fade into the space underneath the road so that we never have to worry about it. And we also need things like a science of interprofessional collaboration and interprofessional work, because we are in an environment that is where we have not only people working together in interprofessional teams, but also the individual professional culture of each of the professions that provide care within our health system. And so understanding these dynamics separately for each profession will help us understand willingness and readiness to change, potential professional culture obstacles to change in the context of a specific organization, as well as to help us understand some of the really difficult dynamics that will prevent change from happening. There are potentially other sciences beyond that, not to mention sciences of how we actually learn and change, but those are some sciences that I think could be more prominent in the conversation about moving to a learning health system.
Other questions from the audience? Let me take one of the online questions. So question is, what has shifted, or what is your learning community aspiring to change in respect to organizational culture and systems as a consequence of this work? What have you seen change? What would you see change? What would you like to see change? Alexander, do you want to start, or Stephanie?
I'll give a short answer. Give someone smarter than me time to think of a good answer. One of the things that we've seen in sepsis is because there's a publicly reported quality measure for sepsis. It's a process measure of care that gets reported to Medicare, Medicaid. And because that exists, all of the improvement efforts have been targeted towards improving that one metric, which is not closely tied to outcomes patients care about: mortality, hospital readmissions, long-term recovery. This is just a process measure. And so 90% of the really heavy lift quality improvement efforts have been targeting this one measurable measure that gets reported. And in our work, we've listened to patients, elevated patient voice, elevated the clinician voice to really say, we don't want to leave money on the table by doing bad on that process measure, but that's not the outcome we really care about. And so we've stepped back and designed interventions and tested interventions that are more focused on outcomes that patients and people care about. And I think that's a big win.
I guess I can answer, like, specifically in the world of concussion. We have some very specific clinical questions we've been interested in, like, what does it mean if you have orthostatic changes after concussion? What does it mean the way symptoms develop whenever you exercise? So there are very specific, like, I won't go into details about the clinical questions. I think bigger picture, concussion specific, I would love to get to that pie in the sky point where we can make, like, evidence-based, personalized predictions for patients. I think more broadly outside of my own world, I think systematically, I would love to get to the point where this building learning health systems is, again, something that we have a mechanism, every team is able to do it. And, it's not like each one has been developed on their own in a one-off capacity. Like, I really think systematically, that's where I'd like to see things going, and hopefully in the future with AI driving it.
I mentioned earlier that it's difficult to find an outcome measure in bipolar disorder that is both measurable, readily measurable with the data we have, and that people living with a bipolar diagnosis care about. So we are taking the opposite tack, and we're going hard on the process measures. And one of the things that we seek to do, and my colleague Emily Kautz is here, she's leading this initiative to try to understand how patients actually find their way to the specialty clinic, and to look at the process of that, potentially optimize the process and improve accessibility for specialty bipolar care. So this will be a lot of process improvement and process measures. And from there, we can begin to develop different kinds of outcome measures where we're getting closer to things that people living with bipolar disorder value. But we do know that one thing that they value is being able to actually get care. Yeah.
Well, I would love to hear about that as an oversight leader, because we are working on access, right? And then I think that's where, one, having shared data is super important for finding shared understanding. There's a lot of friction between the departments and the divisions and the ambulatory group, right? But where we see opportunity and you see opportunity is where I feel like there's great opportunity to think about how to improve care outcomes and access for patients. So that's where I see the synergy.
I just don't want to skip over this really important tension in learning health systems on outcomes, and the tension between something that's measurable with relatively little effort, but important to patients. And I think when the learning health system originated, it was focused on the health system. So it was outcomes that the health system cared about that would save them money or otherwise be beneficial to the health system. But folks like you and others have really brought up this idea that it's not about the health system, it's about the patient, and the health system should care about the patient. And yet often the health system funds some of the LHS work, and so it has to be helpful to the health system. And so does anybody have any thoughts on what is the domains of outcomes that we should be measuring and going after?
I don't have an answer, but I just want to say that's an amazing question. It is a tension that I've experienced as well. And part of the patient focus is, there are learning health system builders, predominantly the Cincinnati group, where they come from the QI tradition and they leverage quality improvement to build learning health systems and learning health networks. And they're very focused on outcomes. And it's ideally outcomes that I think the theory would be that if you pick a health outcome that matters to patients, you can begin to organize care around that outcome. So you're not trying to boil the ocean. And along the way, you can do things that benefit the system, starting at the workflow process within a clinical setting and working up from there. That's sort of the theory. But I do think that there's an important way in which we have to be always thinking about what is the win-win here. It can't just be, we privilege everything that matters to patients or everything that matters to health systems. There are so many things that are important to improve, so much low-hanging fruit that I know we can create win-wins for quite a long time while we're doing a lot of this organizational change, so that later on, if there's something that's not a win-win, people will have a lot more confidence that it's a kind of temporary situation.
So I think that's where the integration of data is super important. And I can tell you that I work with endocrinology, pediatric and adults on the kind of the quality / outcome side for Caswell, right? And then I work with ambulatory, and A1C is not on any of the dashboards for ambulatory, nor their quality of life metrics, for example. So one, the siloization, right? Two, the lack of visibility between two different groups who are working with similar kind of patient population. And then three, how do you bring it all together to get the win-win? So where is their investment that actually leads to other outcomes that people care about on the other side, which is like ROI or personnel or budget, right? That's where I think there's interesting opportunities. So technically right now as an ambulatory leader, I'm agnostic to A1C, right? But then the question becomes, what's that mutual opportunity to think about it? So Care Companion, I've talked about it, right? It's like a tool that I know of because we were working with it on the metabolism diabetes side. Well, it turns out that you can make it message patients 3 days before the visit to tell them to submit their downloads for clinic. And we actually had personnel doing that. So we're getting virtual care to build it. It's going to reduce the burden on the clinic. And the question is, what do you embed in it on that side to improve the preparation, to improve the education, to improve some of the, so I think that's where you have to find these opportunities, but you have to talk to each other to find the opportunity. I talk to myself, right? I dialogue with myself, but I do want our teams to dialogue more. That's part of our barrier, right?
I want to just put one more question out there as our time's coming out from online. It wasn't even a question. It said, I wonder if anybody's ever done a study about the accuracy of EMR data, but it's not 100%. There's an understatement. So the LHS.
It's like 50%.
Maybe. I hope it's better. Oh my
I don't know. It's not great. It depends. We all the time are charting respiratory rates of 100 and excluding outliers all over the place. I mean, there's methods to account for that, but there's a lot of inaccuracy.
So the question I have is, the question that comes out of it is that LHS is dependent on clinical data. That's how it works. AI is coming into the world. I could entertain you all with funny stories about ambient AI, right? We could all talk about that for another 3 hours. I fear this. Can you make some comment about how our dependence on clinical data and how AI may affect that and how it is even now?
Can I just add an interject to that question because I think it is my role.
Hang on a second.
Okay. I'm Vinod Vaidiswaran. I am with the Department of Learning Sciences, but I also am the graduate chair for the program. So in a way, I'm putting on the education hat right now. And you kind of talked about data quality and the role AI would play in making it messier before it can get cleaner. But then across the panel, you talked about kind of education piece in multiple ways. You talked about data data analysts understanding. You talked about physicians try to interpret data in a way that can be more trustworthy or more reliable. And you talked about how interprofessionals can talk about it. So is there, in addition to a learning health scientist training, are we kind of saying that there is also a need for a much more of an educational training program to work with clinicians understanding data, or people who are directly kind of working with data being more than just data analysts, but really everybody in the health system knowing that?
Thank you. I'm just going to very briefly say, I don't have anything smart to say about AI, but I want to challenge the premise of the question a little bit. Yes, the learning health system involves a ton of clinical data. And insofar as you can put something into the electronic health record, I guess it becomes clinical data in some way. But learning health systems also collect original data. They create their own data. And there is also, this hasn't come up yet, but patient-generated health data. All of the smart watches, et cetera, all of that is integrated to better and worse ways into care currently. But there are a lot of people who are quite invested in their own tracking of their everyday stuff. And so that might become clinical data if we can get it better integrated. But right now, I would say that that's a data source without a home.
Yeah, in my role as a division leader, we have sort of service line leaders who make decisions about their service. We have them go through kind of a basic interpretation of data kind of training so that we know that they're making decisions in a way that's trustworthy on the data. So probably not every clinician needs to have that training, but anyone who's going to be making decisions, I think should. It sounds like you've been thinking about that too.
Yeah, maybe not a lot more to add, but I mean, I would agree. Like whenever we see data on a dashboard or in a spreadsheet, yeah, I mean, I guess the best that our group is doing is like looking at it and says it makes sense. If it doesn't make sense, there's probably something wrong with it, and there's probably ways AI could help, clean it and filter it. I don't have a lot better answer than that though.
Yeah, I guess the only comment I would make is in ambulatory, we have like 3 key different dashboards and the numbers are all different. So everyone mistrusts the data because the numbers are all different. But I say, no, it's because the data models are different. So understand that we don't expect the same numbers from every dashboard. So I guess it's really around visibility, trust, and I think, yeah, like greater sophistication around how to interpret it. I feel like every clinician should know how to work with data because this is our new reality. And I think we're far behind. So I think there's a lot of opportunity.
We have about 5 minutes left. I wonder if the panelists have some final comments they'd like to make. Everybody want to take a minute to make a final comment. JT, you want to start or?
Final comments. Thanks for inviting me. Enjoyed sharing my story with everybody. I do hope that, big picture institutionally, it sounds like we are working towards some of the, how-to manuals and support systems that I think I would have benefited from and my team would have benefited from back when I looked like I did in the picture. But I think that will be great. Again, back to the analogy, like once we have planes we can all get into, I think we can fly all over and do all kinds of cool things. Once this is more something that we can set up more easily.
We can do it. There's a ton of expertise in the room, and it's not just on this side of this particular table. So that will be my closing words.
That was unbelievable. Turned out even more fantastic than I knew it was going to be. So thank you so much. Please come back on May 14th. We talked about patient involvement and we're having Dr. Michael said from Cincinnati is going to be focusing on that. So everybody come and see that. Hey, Stevie credit? Be there.